The brain consumes 20% of the body's total oxygen, supplied by a vascular network operating under high systolic pressure directly from the heart. Predicting the pathology of a stroke requires a precise understanding of this neurovascular blueprint, the specific pathways blood must take to reach cerebral tissue. This flow begins at the aortic arch, branching into the brachiocephalic trunk, the left common carotid, and the left subclavian arteries. As the common carotids ascend the mech, they reach a bifurcation. The external branch feeds the face, while the internal branch continues upward to enter the cranium. After passing through the carotid canal at the skull base, the internal carotid transitions into its terminal branches, the anterior and middle cerebral arteries. This group constitutes the anterior circulation, a closed territorial system responsible for the frontal and lateral aspects of the brain. Because this network exclusively feeds the cerebral hemispheres, any inclusion here is anatomically confined, sparing the brainstem and cerebellum while targeting the higher cortical structures. The posterior circulation follows a different path, beginning with the vertebral arteries that rise from the subclavians and ascend through the cervical vertebrae. At the base of the brainstem, these two vessels merge into the singular basilar artery, which sends lateral perforating branches into the pons. The basilar artery terminates in the posterior cerebral arteries to supply the occipital lobe, while lower branches like the pica and the anterior spinal artery feed the medulla and spine. The anterior and posterior systems are linked by the posterior communicating artery, a physiological bridge between the two circulations. As shown in this hand-drawn diagram of the Circle of Willis, these junctions allow for limited blood shunting, but their branching geometry makes them primary sites for the formation of baryaneurysms. This completed map provides the full structural layout of the brain's dual system supply. Any disruption at these specific branching points bypasses local redundancy, leading to targeted tissue death in the regions served by that specific vessel. When a vascular occlusion occurs at the microscopic level, it instantly halts the forward flow of blood and starves the tissue of oxygen. In the brainstem, where the blood supply is hypersegmented, even a small occlusion produces massive, highly predictable neurological deficits. These are pathognomonic syndromes, clinical profiles that point to one exact anatomical lesion based on the symptoms presented. Examining a cross-section of the pons, we can isolate the territory supplied by the anterior inferior cerebellar artery, or AICA. A blockage in the AICA causes ischemia in the lateral pontine tissue, a condition identified as lateral pontine syndrome. By identifying which cranial nerves are failing, a clinician can reverse engineer the patient's symptoms to locate the specific occluded pontine artery. Moving down to the medulla, the diagnostic rules remain the same, though the vascular players change. In this region, a stroke typically involves an occlusion of the vertebral artery, or the pica. This results in an ischemic wedge in the dorsal lateral quadrant, the anatomical hallmark of lateral medullary syndrome. This is known as Wallenberg syndrome, which presents with a specific loss of pain and temperature sensation on one side of the face and the opposite side of the body. These posterior circulation strokes manifest as localized sensory and ionomic failures, contrasting with the hemisphere-wide motor deficits seen in anterior infarctions. In the emergency department, stroke is a broad umbrella term that requires immediate systematic deconstruction. We first divide the event by etiology, arterial or venous. We then subdivide arterial strokes into ischemic blockages and hemorrhagic bleeds. Ischemic strokes are further classified by their location, either the anterior or posterior circulation, using the vascular maps we've established. We also define the mechanism, a thrombus formed by atherosclerosis, or an embolus traveling from the heart to wedge in a smaller vessel. Determining the anatomical location and the mechanical cause is what dictates the immediate treatment protocol and the patient's chances of recovery. On the hemorrhagic side, we focus first on subarachnoid hemorrhages, which are often the result of a ruptured baryaneurysm. As noted in these clinical markers, systemic conditions like Marfan syndrome or polycystic kidney disease increase the risk of these abnormal arterial dilations. Finally, we distinguish these subarachnoid bleeds from intraparenchymal hemorrhages, such as those caused by the rupture of Charcot-Bouchard microaneurysms deep within the brain tissue. Viewed side by side, the difference is clear. An ischemic stroke starves the tissue, while a hemorrhagic stroke actively destroys it through invasive pressure. Every stroke diagnosis is a structural challenge. Mastering this neurovascular blueprint is the only way to identify and salvage brain tissue